Dropping blood pressure, leaks in the breathing circuit or leaks in the lungs, any kind of lung problems, you need to consider whether the patient is suitable for lung recruitment.
What is the contraindication? High intracranial pressure?
Yes, high intracranial pressure, eye surgeries, lung problems like pneumothorax or
COPD.
Yeah, COPD, it's a relative contraindication, or ARDS is a relative contraindication.
The absolute? The absolute one?
No.
No.
Okay, but the problem with ARDS is okay. So if you do lung recruitment in ARDS patients, usually they don't improve because they need high PEEP. Okay, so when you do lung recruitment, no improvement, then why are you doing it? So it's a relative contraindication. So for patient, for lung protective ventilation and lung protective strategies, there are 4 different components. First is the optimal FiO2 setting. The second is the proper PEEP setting or individual PEEP setting. Then lung protective ventilation, okay, and lung recruitment. Okay. But these 4, it cannot be done in just any order. Okay. So for example, for FiO2, okay, the recommendation now is to give the lowest FiO2 to keep the patient's SpO2 above 94%. If you keep on giving 100% FiO2, first, it's not safe because it can cause lung collapse because oxygen is very absorbable. And the second thing is, if you give high FiO2, you are masking other problems that the patient has. Okay, so for example, if the patient's lungs collapse, you will not see the SpO2 decrease because you keep on giving oxygen 100%. Okay, so you are treating oxygen lung collapse by giving high oxygen, not by doing lung recruitment. Then PEEP, for example, we know that we use PEEP to keep the lungs open. Okay, but the PEEP itself cannot open a collapsed lung. So before you use the proper PEEP, you need to open up the lungs first. To do lung recruitment, there are many ways. One of them is to use cycling. So procedure cycling. What it does is it gives you progressive increases in the patient's PEEP. So it's divided into different phases. Okay, so for the settings here, these should be individualized. So there are it should be individualized per patient. So what we have provided here is just a template. It's just an example. It's I am not saying that you use this for all your patients. It should be individualized. Okay. So the for this kind of now recruitment is divided into 3 parts. So first is hemodynamic conditioning. Okay, what it means is you want the patient's hemodynamics to get adjusted before you do the actual lung recruitment. Okay, so when you inflate the lungs, you're actually squeezing on the heart. So then the heart cannot give enough blood, and not enough blood returns to the heart. Okay, so you're expecting changes in cardiac output, changes in heart rate, changes in blood pressure. If they change by more than 20% when you do this, okay, you give your fluids or you give your vasopressors like ephedrine. Okay, so when you start, okay, it gives you low peak and low inspired pressure. Okay, for the first 3 breaths, then afterwards it slowly increases the peak in steps of 5 until it reaches 20. Okay, so if patient blood pressure changes, other hemodynamic parameter changes, okay, you address that first, you stop, okay, you give fluids, you give vasopressor, then you repeat this again. If the patient's hemodynamics can tolerate, then you proceed with the actual recruitment, which is here. Second. So it's inspired pressure of 20 and a peak of 20. So that gives you total pressure of 40. Okay, so studies show that it takes 40 centimeter water of airway pressure to open up the lungs. For obese patients, you may need higher pressures, like around 50, 55.
Normal patient 35 up till 40 is enough.
Yes, for normal patients. Okay, so for smaller patients like children, babies, you will actually need lower, like 25 or 30. So here, yeah, 20 and 20. For this example, because it's a healthy patient, I just did 15 and 20. So total of 35. And you give it for at least 10 breaths. Okay, so after 10 breaths, the lungs will have already opened. Okay, and now the next challenge is how do you look for the correct peak setting to keep the patient's lungs open for the rest of surgery. So to do that, we go to procedure 3, which is PEEP titration. So for PEEP titration, we start with high PEEP. Every few breaths, we decrease the PEEP in steps of 2. And what we want to do is look for the patient's compliance. So when the PEEP is very high, the compliance is very low because the lungs are already full. It's difficult to inflate more. So when you start decreasing the PEEP, you see the compliance start increasing because it's becoming easier to inflate the lungs. But eventually, after the patient's optimal PEEP, if you keep on decreasing the PEEP, the compliance will actually start dropping because the lungs start collapsing again. So the point where the compliance is the highest, okay, corresponds to the patient's optimal PEEP. So if it happens in a PEEP of 10, for example, we add 1 or 2. So the patient's final PEEP setting will be 11 to 12.
Where's the compliance? The red one?
This is the compliance.
Oh.
Yeah.
This is what graphic, right?
Oh, this is the airway pressure, the maximum pressure,
And blue one?
the pressure limit. This is the inspired pressure. This is the PEEP.
Oh.
So PEEP of 18, then plus 12. Total 20. So after doing this, you find the correct PEEP setting. So for example, if it's 8, you add 1 or 2, then the final PEEP setting is 9 or 10. And then you can proceed with setting the correct PEEP. Okay, so now since the lung is open, you can start giving lung protective ventilation. So lung protective ventilation strategy right now is giving 6 to 8 mils per kilo, but ideal body weight. Okay, so if the patient is fat, that does not mean the patient's lungs are lighter. Right? So you use the ideal body weight. So 6 to 8 mils. So for example, it's 400. Okay. Then you adjust the tidal volume and the rate, okay, to give you normal end-tidal CO2 or the end-tidal CO2 that you need. Okay, so sometimes for neurosurgery, you actually need lower, then you need to adjust. Okay, but for normal patients, you target normal end-tidal CO2. Okay. So because the lungs are now open, it's easier to give lower tidal volumes because there's more oxygenation, there's more area in the lung available for gas exchange. So right now it's 36. That means you can still actually decrease the tidal volume even lower. Okay? Because right now the rate is 10. So aside from targeting the CO2, you also target driving pressure. Okay? So recommendation now is to keep the driving pressure below 13. In very healthy lungs, up to 14 or 15 is okay. But for most lungs, below 13, 1-3. Okay, so how do you look for the driving pressure? Unfortunately, it's not in the screen. Okay, you need to do a bit of calculation. Okay, so you subtract the peak from the plateau pressure. Okay, volume control. In pressure control, you subtract the peak from the peak pressure. Okay, because in pressure control, the peak pressure is flat. So that's the plateau pressure. So right now, plateau pressure 18 minus 9 gives you 9, which is less than 13. So that means this is lung protective ventilation. You're not giving strain to the patient's lungs. So you can only get plateau pressure during volume control if you put in an inspiratory pause.
0.2.
Yes, it should be at least 0.2 seconds. If the inspiratory pause is too short, there's not enough time for the air in the lungs to distribute to the smaller, farther regions in your lungs. So you need at least 0.2 seconds. Okay, so you can do that by looking at the inspiratory time is 2 seconds. So 15% of 2 seconds is 0.3. So that's enough time for the gas release. So next, okay, so you look at the FiO2. So FiO2 is around 40%, and your patient's SpO2 is 99. Okay, so this can actually go down lower if you want. The thing to remember about FiO2 is you treat the patient, not the patient's lungs. You treat the whole patient. So if there are conditions in the patient that require you to give more oxygen, do not hesitate, okay, to give more oxygen. Okay. It's no use keeping the patient's lungs open if the patient will not be alive after the procedure. Yeah? So treat the whole patient, not just the patient's lungs.
Okay, thank you very much.
Yeah, thank you.